Hello and welcome everybody to our fourth annual Ontario West Midwifery Conference, and what is specifically day two, which is a day that focuses on innovative clinical programs. This has typically been one of our most popular days throughout the previous 4 years that we've been hosting this program. So we're very grateful to everyone who's joined us today, and especially to our speakers. Just a few little housekeeping items. We have a very nice packed day of speakers today. Each speaker will speak for roughly about 14 minutes, and then they'll have a few minutes afterwards for question and answer. So you can put in any questions you have into the Q&A box, and if they don't get to them live while they're speaking, they can answer them afterwards if they have the time. My name is Lauren. I am the academic practice lead for the Department of Midwifery at London Health Sciences, and I'll be the host for today's session. I'm really excited, really grateful to get started, but we're going to start off with a quick land acknowledgement and acknowledge that the sacred land upon which we are privileged to live and work here has deep connections and longstanding relationships between Indigenous people and our Southwest Ontario and the area of London. This land has supported human beings for over 10,000 years, throughout which, has included 10,000 years of midwifery care, and is the traditional territory of the Anishinaabe, Haudenosaunee, the Attawandaron, and the Wendat peoples. We're very grateful to have the opportunity to gather today in this place and acknowledge that we try to embed work of truth and reconciliation in all that we do here in our department. All of you will have your videos automatically off and your mics muted, and it's only the organizers who can turn you on. And we can do that if you would like to ask a question live on the mic, just let us know. All right, so we're going to get started with our first presenter of the day, which is Jennifer Jollimore. So she's welcome to turn her video on and take control of the screen. She is an advanced practice nurse from IWK in Halifax, Nova Scotia, and she'll be sharing her talk entitled The Full Moon Challenge, Improving Birth Outcomes Through Staff and Family Engagement. And you'll be able to see her bio in the chat, which is how we will share everybody's bio throughout the day.
Thank you, Lauren, and thank you to the organizers for inviting me here today. It's not lost on me that I am a nurse among midwives, and I'm super grateful that you've included me here in your wonderful conference programming. I did have the opportunity to join in yesterday afternoon and listen in, and it was a great session. As Lauren mentioned, I'm an advanced practice nurse, but I do consider myself an honorary midwife, if that helps. I love midwives. And I'm joining you from Halifax, or Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. The original title of this presentation, which I did at a national conference last year with a colleague, was Improving Birth Outcomes Through Nurse Engagement. But we titled it The Full Moon June because that was the name of the initiative that we developed and ran at the time, but it has since morphed into the Full Moon Challenge, which is what I will be sharing today. And I have no disclosures. I thought it might be helpful to give a little bit of our local context here. We have just under 5,000 births a year at the IWK, which represents about half of the births in the province. The data around the C-section rates was taken from 2023-2024 data, so I don't have updated numbers for you at this time, but then we were sitting at about 30% cesarean birth rate with a primary cesarean birth rate around 22%. And we have seen that rate steadily increase for decades, which is consistent with the trends across the country. And I thought it was interesting to note that our breakdown of births by providers is only 5% midwifery attended, which hashtag Nova Scotia, where's my midwife, right? And the rest fall to family medicine and obstetrics. I will note as well that our epidural rate for total births is about 70%, which I feel is a bit misleading because our book C-sections don't get included in that. So I think our epidural rate for vaginal births is actually much higher than that. So let's jump right into the project. We had several goals for the initiative, including increasing staff and team member engagement with the use of an interactive display and incentives, increase family engagement using the same display on the unit and on social media and other media outlets, and improving birth outcomes by encouraging frequent and upright position changes in order to shorten labor and decrease interventions. Where did these goals come from? Some were driven in part by my work as a CNS. Many of the patients I'm consulted to have a history of previous birth trauma. There are so many similarities in the stories they share, none of which are likely surprising to you folks. But they telling the kinds of things like how they got, started with an induction, oftentimes, and then they get an epidural, and then they just laid there. They didn't know how or when to move. And then when their progress ultimately slowed or stalled, the cascade of interventions began, sometimes ending in a C-section, sometimes ending in assisted vaginal birth or retained placentas, things like that, postpartum hemorrhages. And we know from the literature that as the number of interventions increase, the risk of birth trauma increases. More broadly, our goals originated several years ago in a working group, and that working group was called Reconceptualizing Birthing Culture, or RBC for short, not to be confused with the bank. We consisted of 2 clinical nurse specialists, myself and the one who worked in prenatal at the time, and a midwife. And then we were later joined by a clinical nurse lead from one of the units we were devising a project within. And, it's it really we couldn't have known 3 years ago when we were setting out our goals what things would look like 3 years later. But it's fascinating to me that in 2024, when we started this in 2021, the Full Moon Challenge really has taken off and it kind of exploded in my world. And that really aligns with lowering our intervention rates, which was one of our goals, with fewer inductions and C-sections, and seeing IWK Health as a regional leader in normal physiological birth, which I'm really happy to share that many of our regional hospitals across Nova Scotia are engaged in or have engaged in their own full moon challenges and like really running with it in ways that I couldn't have dreamed. Super exciting. Everyone recognizes this scenario, right? Especially with an epidural. It's so common that all myself and my co-presenter at the time had to do to find it was Google laboring pregnant person, and this was the first thing that popped up. We know that this is not optimal positioning for many reasons, such as increasing pain and labor and the length of labor. We noticed that there had been an increase in the use of different positions and positioning aids among our nurses with patients, but we wanted to provide more guidance and direction on optimizing the timing, frequency, and order of position changes. Since the implementation of this project over 2 years ago, our staff now use the term semi-foulers of neglect if their patient has to spend any amount of time for any reason like this. Unanticipated outcome. So what is the full moon challenge exactly? First off, I find it helpful to think about the cervix as a circle so that when we're planning position changes, we use positions that put pressure on all parts of the cervix the whole way around. We knew this wasn't happening routinely on our unit after we completed chart audits prior to the start of the challenge. There were documented position changes happening, but majorly using side-to-side positions, maybe with or without a peanut ball, on average hourly. You can see from the info here that instructions to complete a full moon included changing position every 20 to 40 minutes, shifting from left lateral to upright to right lateral to forward leaning continuously throughout labor, or as the situation warranted, or as the patient or client wanted, but is simply a baseline to work from. So the full moon is a fusion of the 3-point position change and Penny Simpkins rollover. The photos used in the slideshow here and in the following 4 slides are of our very own birth unit nurses at the IWK. In 2021, we had an initiative called Position of the Week, where we would photograph a nurse and display a labor position, highlighting the benefits of that position. We were able to include those photos in the Full Moon Challenge as well, though we have since had some photography support from a professional. So some examples of the positions in each sequence of the full moon cycle. I don't think I need to go into any great detail of the benefits of the different positions to this group. You are well versed in all of that. Uh, but our goal is to highlight all of the variations that can be done within a different sequence of the full moon. So here's Patty and Lauren doing some sideline releases, and Lauren in a bit of a runner's lunge with some pillows, and then upright, incorporating, different angles, use it with or without the peanut ball or out of the bed, as depending on if you have a walking epidural or not, or maybe you don't have an epi. But I find people with epidurals don't usually need a lot of prompting to move. There's Lauren trying a few different things with the peanut ball and right lateral. Uh, Particularly like that flying cowgirl in the middle photo to help with those babies that need to engage. And then forward leaning, which can be done both weight bearing and non-weight bearing, depending on a person's bromage or any other physical limitations that they might have to really get that forward angle. So the main outcome we were interested in was team member engagement. Did people do the thing we wanted them to do? Across from our main desk on the unit, there was a large full moon tracking board. Many examples of positions were posted, and there were cut-out paper moons with markers and tape available. Nurses who helped their patients to complete a full moon were asked to self-report by writing their name on a moon and sticking it to the tracking board. The visible posting and tracking of completed moons helped to normalize the practice and create momentum amongst the team as they saw the number of moons grow. We incentivized by offering to do a gift card draw for those who participated 1 month after the launch of the challenge. Uh, 14. We shared the number of full moons completed by our team in a private Facebook education group. So as you can see, week 1 there were 4 full moons. Week 2 we doubled to 8, and by week 3 we jumped to 38 reported full moons. When considering how new ideas get adopted, our results are consistent with the diffusion of innovation theory, having our innovators and early adopters in weeks 1 and 2, followed by the early majority starting in week 3. And the sharing back of these engagement numbers in our education group helped to promote awareness and excitement about the initiative. I also think it's worth noting that there's something sticky about the full moon branding. I personally have taught the 4-point position change for years to new nurses on our unit when they go through orientation. We always do a share back at the end of the day, and nobody ever references the 4-point position change. But since I've incorporated that language, it's often shared back as something that people are going to take away. And that's the beauty. Anybody brand new to the unit can do it. We were pleasantly surprised when we were tagged on social media by local doulas who were supporting families during the challenge. And then we had also shared the Full Moon Challenge on our at IWK Pregnancy Instagram page so that families would know about the initiative when they came in to have their babies. And here's what happened with our unplanned C-section rate before, during, and following the challenge. Prior to the start of full moon June, the unplanned cesarean birth rate for the month of May was 25%. In June, the month we launched, it was 22%, but you saw how we sort of had slow uptake in the beginning. And then as momentum grew, we decided to keep tracking and looked at the following month, which came down to 18, and then the following month came down to 16%. Thank you. I see the hearts and claps. I appreciate that. I wish that we had known this at the time. We didn't quite pull it right away. And then in September, it did creep up to 19 again. We had stopped, the display came down and we'd stopped tracking and sharing back with the team. And, influx of new staff and new residents and things like that happen. So we weren't super surprised to see it level out a little bit. Um, and a competing of priorities and other things really did lead to a delay in auditing that data, as I mentioned. So it was when my colleague and I were preparing to present this last fall at a national nursing conference that I said we should probably look at some clinical outcomes, and we went through and pulled that data. So that is why we didn't know right away, and we have since shared that back with the team. Uh, we have done audits for May of 2024 and May of 2025, and the rate has consistently been sitting at 18% for unplanned C-sections. So what's next for us? The interest, excitement, engagement that we experienced at the national conference was something we weren't really expecting, but people loved it, and that did help us to form a national working group. And we are looking at, well, first off, because of the interest, people have been asking for resources, and so we are at the final stages of developing a toolkit to support at other sites, and that should be out in the next couple of weeks. That national group is looking at multi-site coordinated research, so we are putting together some grant applications. And finally, through all of the literature that I was into in preparation for this work, we're all very excited here for the to look at the labor hopscotch framework out of the UK, which again might not be a surprise to this group, but I'm really interested to see how implementing the framework antenatally could further help to decrease our C-section rate. So thank you very much for your time, and I'm happy to take any comments or questions, or happy to connect by email. Thanks.
Oh, thank you so much for sharing this, Jennifer. This is like just the best example of like real frontline initiatives that bring about clinical change. And I think so many of us who, are on this call who are practicing actively in intrapartum care, this means a lot to them. So congratulations. And I know, our site has adopted your position of the week in our newsletters, and are hoping to do a little bit more of the implementations that, we chatted with you about back when we met you. But if anyone wants to throw any questions into the Q&A box, please feel free to go ahead. Otherwise, someone DM'd me a question, and I have a couple as well that I might ask just while we're waiting. But the curiosity around how anesthesia reacted to like lots of different positions and movement for these clients.
Lauren, that is a common one that I've heard, like from folks across the country. And I don't know if our anesthesiologists are just used to us here, but we we have not had any pushback from them whatsoever. I would say, some of the bigger challenges are around that position at the time of birth when it comes to perhaps certain care providers not being adaptable to anything other than semi-valors, to put it diplomatically. Uh, but no, no concerns or barriers from anesthesia other than when I presented this to them. Are you ready? They questioned the evidence around movement in labor helping with the progress.
Oh no.
Yeah, I know.
Oh, that's hard for
I
everyone
I
here
know.
to
I didn't
hear.
do an
Yeah,
RCTA. I haven't proven anything, but
sure. Yeah.
mm, yeah.
Yeah, I think that's pretty fair. Someone in the chat asked about the concept of walking epidural. So on a related note to sort of anesthesia, I think across the world, country, province, there's a lot of different rates of infusions and also different medications that are used that can vary whether people are, safe to actually walk or not. So I take it you must use a dose that allows for some degree of movement.
Yeah, so we for years did a continuous infusion that that I found people could mobilize fairly well with. We some years ago switched to the intermittent bolus, and I find it's a bit more variable in terms of if people can mobilize easily. However, everything within the full moon is adaptable to somebody who cannot weight bear.
That's good to know. Yeah. I think from an intervention perspective, being able to change infusion rates versus bolus dosing versus, concentrations of, medications used probably feels overwhelming to people, but position changes are within, nursing and midwifery purview in terms of being able to tackle. So that's good to know that it's adaptable for non-weight bearing. Yeah. We had a question in the Q&A about how did you get your staff engaged in this, and especially seemingly very quickly.
It's interesting. I had the same success a number of years ago when we implemented uninterrupted skin to skin after birth by using the principles of behavior modification. It's very motivating to groups when you publicly post results, right? Nobody wants to be the one left out. And so that is essentially how I think we were able to shift things quickly because we were also able to implement skin to skin immediate skin to skin after birth up to 80% of the time within 6 weeks when we did that initiative.
That's phenomenal. And I love that you're relying on sort of the psychology and some of the like known, like you said, science behind behavior change to roll these out. So I wish every birthing unit could have a person like you and someone with your sort of resources. Meg just commented about change being so hard in organizations, but it sounds like you've got a good grasp on the science and psychology behind how to get your group engaged. So yeah, congrats again.
Thank you.
And for anyone who, if you're able to stay on for a few minutes, if there's any other comments or questions that come through, please feel free to throw them in the Q&A. And thanks so much, Jennifer.
Thank you so much. I'm a big
Perfect.
fan of the magic that can happen when nurses and midwives work together. So thank you.
Same. Yes. Wonderful. It's so great to have you here today and make the conference a little more interdisciplinary. So next up, we're going to move to a group of presenters who will be spotlighting three amazing expanded midwifery care models from across the province. Our first speaker is Andrea Levy, who is welcome to turn her camera on and take control of the slides. She is a registered midwife in North York General Hospital's Midwifery Care Clinic, or MCC, and she's the head midwife at North York General. So I'll let her take it away if she's able to figure out our slide deck here and get started.
Thanks, Lauren. I did take control. Oh, hang on. Here we go. Okay. Hi, everyone. Thank you. Okay,
Looks good.
so yeah, I work at North York General, which is located in the north end of Toronto, and we have two midwifery practices that work out of North York General. And we now also have what we call our midwifery care clinic. So that is what I'm going to talk about today. Okay, so the program is a hospital-based outpatient clinic. It is managed by the clinical team manager for a postpartum unit, supported administratively by our admin staff who work in this clinic as well as our newborn follow-up clinic. We share the same space, and it is staffed completely by midwives in terms of who is providing the clinical care. Mostly we see postpartum dyads. So I would say probably 90% of the visits are for breastfeeding support. We do follow-up, lots of follow-up billies between us and the newborn follow-up clinic, which is staffed with nurses. And well baby visits. We have recently expanded our scope to include well baby visits up to 8 weeks of age, and that includes the routine vaccinations that are given at 8 weeks. We also see the postpartum birthing adults when they have concerns such as wound infections, hypertension, other concerns that they would otherwise have to either try to get in to see their primary care provider try to book an appointment with their OB, which may not be possible for days to weeks, go to a walk-in clinic, or go to Emerge. So this has opened up an option for people to seek care in a more timely manner. So the objectives of this program primarily were to close gaps in care. And so many of our patients are unattached to a primary care provider in the first few weeks postpartum, and then they can get help in finding one through this clinic. Or, like I mentioned a minute ago, they're people who are not able to access their primary care provider within a reasonable time frame that is required for their clinical situation. And they would otherwise have to go to the emergency department. So that was our primary goal. So the idea started a few years ago. We've been up and running, sorry, I think I forgot to mention this in my slides, but we've been up and running since 2022. So several months prior to that, we became aware of the ministry call for submissions for EMCM proposals. And between our two groups of midwives, the MPG midwives, what we really wanted was funding for some kind of intrapartum and or postpartum hospitalist to close gaps in care for primarily for the obstetric population, but also for our clients and to decrease midwifery burnout. So we were sort of thinking of a hospitalist who would like start inductions and do NSTs and triage assessments and, work collaboratively with the nurses and the obstetricians. On the hospital end, the North York General leadership for years, like even maybe 10 or more years ago, have been talking kind of off and on about wanting a postpartum short stay unit for those birthing people who do have conditions like wound infections or postpartum hypertension or other things where their only options are to try to get in to see their provider or to go through Emerge, which is, Emerge is sort of the least desirable option for people when they've just had a baby and they're feeding and etc. So we drafted a proposal for this intrapartum hospitalist, and then part of the process involved being reminded very nicely that EMCMs they really exist to close gaps in care in the healthcare system, but not so much to provide care to midwifery clients that are already being provided and funded by MPG midwives. So that became not so much of an option. So we went back to the drawing board. We submitted another proposal, which is now our midwifery care clinic, and that was obviously accepted. Okay, so the people. So it was really a very small group of MPG midwives who drafted both of these proposals. One midwife drafted one. She was at the time looking for an alternative way of working. So she had drafted a proposal already looking at postpartum care. Another midwife who's a strong proponent of an intrapartum hospitalist midwife drafted the first one that we submitted. And then we ended up combining the two and submitting our final proposal. I was involved as the head midwife. Our clinical team manager on our postpartum unit was involved, our chief of obstetrics, and our program director. So we all worked together to put together the proposal and the vision really for the clinic that we wanted. The money came through the ministry. It's funded as an Ontario midwifery program, expanded midwifery care model. We were approved for a 2.0 FTE. I believe maybe they increased it a little bit over the last several years, but we're still basically running on a 2.0 FTE. This funds one full-time midwife. So there's one midwife who does a 0.9 FTE, we have one part-time midwife who does about a 0.4. These are midwives who not also do caseload midwifery. This is their primary occupation. And then we have a team of several midwives who do casual work, casual shifts. And these are all midwives who work at the hospital as caseload midwives. And then they do shifts here and there when they have off-call time. It includes, so that funding includes funding for the head midwife, for clinical and administrative oversight, and the funding includes administrative support. So we have secretarial support for booking appointments. So some of the challenges we came across, ideally we pitched this idea to our family health team to be a partner in this, and they did not have the capacity to collaborate with us, so we moved on from that. I mentioned about having to rewrite our proposal. We do find sometimes that we do submit born data, but because the born data collection is really meant for, kind of the whole journey from pregnancy, birthing, and then postpartum, it's the data that we're collecting is very limited in terms of what data are really useful for us, but we do it because it's a good thing to contribute to. And the other challenge is just difficulty staffing the clinic to capacity. So we run 24 hours a day, 7 days a week. Sorry, not 24 hours a day. We're open from 8 to 4 every day, but it is 7 days a week, 365 days a year. And so even though we provide time and a half for stat holidays, because our caseload midwives are very busy being on call and catching babies, we are sometimes challenged to staff the clinic, especially in the peak months like summertime and in December. So the benefits of the clinic have been great. It's been very well received and is very loved amongst all of the different disciplines and our clients at the hospital. So we do about 3,000 visits a year. At our hospital, we do about 4,000 deliveries a year. So we're seeing lots and lots of our patient population. It does give non-midwifery clients the option for early discharge because they can be booked back into the clinic to do all of the 24-hour things that would otherwise be done prior to discharge. And we've managed to find a way to not charge the hospital facility fee for uninsured patients. So normally that would be about $450 for people just coming into the hospital for an outpatient appointment. And so in the interest of wanting to improve access for these early postpartum people, the hospital has miraculously agreed to waive the facility fee for our uninsured population, which is great. So other benefits include accessible care in the first week. Even though it is by appointment only, we can squeeze people in. Usually people can be booked in within a day or two, sometimes same day. It always helps if we know the midwife who's staffing the clinic, then we can just send them a message and say, hey, can you see so-and-so for us? So especially for non-midwifery clients who are just sort of released into the ethers of the world without really good postpartum support, clinical support for breastfeeding and other clinical follow-up, it's really great that they can access this clinic as often as they need, really. So they're booked in for follow-up visits as needed. And it is accessed by the obstetric, family medicine, and by our clients as well for certain things. And it's been really great, especially for the postpartum birthing people who now don't have to go to Emerge for concerns, because the clinic midwife will just consult with our OB on call, one of our two OBs on call. And so that person gets seen within a fairly reasonable period of time, and then they don't have to go to Emerge or try to get into to see their own family doctor. As I said before, we've added 8-week well baby visits, which is great. There's support to find a primary care provider if people don't already have one. And kind of as an offshoot to this clinic, it's actually led to other initiatives. So we'll be moving our RIG administration program from triage to this clinic. So it will be a more streamlined process for patients. And at one point, one of the OBs and I decided, oh, this would be a great mechanism for midwives to send clients in for an OB consult when, rather than assessing them in triage or trying to get them into OB's offices, we tried to implement this on our own and it a little bit backfired. And so we've now established a separate clinic for this, which is great. Sorry, I see Lauren, I will speed through. So yeah, it's been great in terms of integration. Midwives are working collaboratively. I've been getting lots of great feedback from midwives and OBs that everyone just loves this clinic and they love working together. Lots of support from leadership, which has been great. And it's really been great to provide some midwives with, well, the two in particular, for other opportunities to work in a way that they don't have to be on call. But there is a bit of a balance we have to strike between having enough midwives who are staying in on-call practice to manage our on-call rotations. Really just like be creative, open-minded, good communication. We've been lucky. We've been well supported throughout this process. And yeah, those are all my slides. Made it through. Any questions?
Well done.
Thank you.
Thank you so much, Andrea. I always love to hear about all the different like permutations and variations of these types of postpartum clinics around the province. We do have a few questions that have come in. So
Mhm.
just maybe this is an easy one to answer. How many appointments do you have on a day on average for spots?
It kind of depends on the day, but most of the appointments are booked for about 45 minutes to an hour. And so that ends up, and usually they take in 30 to 60 minutes for lunch. So it's usually about 6 to 8 appointments.
Okay. And another question was, have you been able to help any of the families actually find a primary care provider? Because as we all know, with our primary care crisis, a lot of us are sort of, even if we can expand to 8 weeks, we're still feeling like we're sending people off into the ether. Have you managed to do that at all? Or is that still sort of, you're just constrained by the lack of PCPs in general?
Yeah, no, we do. As you just said, it is challenging, but in the clinic they keep sort of a fluctuating list of available primary care providers and pediatricians who are accepting new patients. That list changes all the time, but they keep an updated list. And so one of the primary goals is by that 8-week visit, people are linked to a primary care provider. I'm sure it's not 100% uptake, but I think they're doing pretty well at finding people, caregivers.
Well done. Yeah, it's very hard otherwise to send people off as many
Mm-hmm,
of us know. Yeah.
mm-hmm,
There were two questions that were basically asking the same thing. And I actually had the same question as well, is just around metrics and whether you've had any capacity to be able to look at outcomes such as, we had two questions about whether you've been able to track whether there's been an uptake or increase in early discharge requests from, let's say, the OB family doc population. So that's one metric. And then I was wondering about whether you'd been able to track or see a decrease in ED visit usage.
mm-hmm. Yeah, unfortunately, we have not been able to track that officially, formally through statistics. We know anecdotally that if someone is coming in, say with a wound infection, they get treated and sent home, and that's one person who is not going in and sitting in emerge. And we know currently our hospital's undergoing extensive renovations, so we actually have fewer postpartum beds. And so we know anecdotally that this is being offered to people here and there, but unfortunately we just have not had a formal way to track it. We're trying to figure that out. It's one of the challenges we've come up across, and Bourne just doesn't capture that. So it's been a bit of a challenge to figure that piece out.
Yeah, as someone who has taken on, the job of tracking that, it's very hard to find that information and it's extraordinarily time consuming to track it.
Yeah. And it's hard to
So
know, like you can surmise that that person would have gone to Emerge instead of coming in, but you don't really know that. They might have gotten in to see their family doctor the next day. Like it's just such a hard thing to track, but we're working on that.
yeah, yeah, I think most EMCMs find themselves in the same position where, yeah, they don't have the mechanisms or the capacity or funding to launch sort of a formal evaluation of some of these outcomes. But yeah, well, thank you so much. And if there's any more questions, feel free to throw them in the Q&A for Andrea. I see one that Jackie's posed, so maybe I'll let you tackle that there about wound infections, and then we'll welcome our next two speakers. So we have Kate Damaris and Mona. I think do I see Mona, or is she not coming? She is here. Okay, perfect.
Yeah,
Mona
I saw her
Abdel.
here.
Oh, beautiful. Okay, perfect. And Mona Abdel Fattah, who are both registered midwives at the Crown Point EMCM in Hamilton, Ontario. They're going to speak on the topic of midwifery-led medication abortion provision at Crown Point. So I'll let you two take it away.
Hi, everybody. I'm going to start off. So I'm Mona. So we're going to talk about midwifery-led abortion care in an expanded model, lessons from our practice, which started in 2018. So we have no disclosures to report for myself or Kate. So who we are, so Crown Point Midwives is an expanded midwifery care model practice. We work collaboratively within an urban family health team. And like I said, we opened in 2018. We have one FTE, but we're about 3 to 5 midwives that share that FTE. So typically what that looks like is midwives will either do a half day or a full day of clinic on their chosen days. And all of our midwives actually are also practicing in an MPG model as well. So what we offer is sexual and reproductive healthcare services. So this includes medication abortion, medication and expectant management for early pregnancy loss, contraception, and that includes like Nexplanon and IUD primarily because we are a little bit more focused on doing contraception that carries longer wait times in our community, but we can prescribe more broadly as well. And then we also have peer support group care, which is mostly virtual peer support around the pregnancy period, postpartum, and we also have a menopause virtual session. So our mandate is to prioritize care within our area, which we're located in Hamilton in an area that has been called the red zone, which is typically a lower socioeconomic region with not great access to care for those folks and a lot of barriers just by virtue of the socioeconomic demographics in the area. We have a very high rate of refugees as well. And so we do have refugees and newcomers, and Kate will provide care in French. I can provide care in Arabic, and we can also and do arrange frequently translation services for people who have a language that we don't speak. So our pathway to accessing care with us, clients can self-refer or they can be referred by a healthcare provider. So if they're referring for medication abortion, early pregnancy loss, emergency contraception, something that we consider a timely need, then that initial contact is mostly done through our pager service. So the healthcare provider can provide the client with our pager number, or sometimes the care provider, less commonly, but sometimes the care provider will call us on the pager. And then we'll have that initial contact with the client virtually. And during that in-person, during that phone consultation, once we have an idea about what their choices are, we can then go ahead and either book them for an initial visit over the phone or an initial visit in person. And that's actually something that we'll talk about a little bit later, is our virtual care options. People will come in person for labs and procedures like IUD insertion. But when we're talking about medication abortion, if they come in, we do tend to do all of their blood work in the clinic as well to save them a trip. A separate trip to the lab. We'll then prescribe them with prescription, and we've developed relationships with the pharmacy in our building and across the street to make sure that they have the medications that we're commonly prescribing, and in particular, mifepristone and misoprostol in stock. And also to ensure that we're not working with professionals who have conscientious objection to abortion care, because we want our clients to be in a safe place emotionally when they're going for their medication prescription pickup. So once they have done their medications, we do follow up. And that follow up again can be either in person or over the phone. And if they come in person, it may be that they've done their blood work in the lab and then they're coming in person for follow up, or that they are coming in and having their blood work done during that follow up appointment as well. So Kate's done a really good job at pulling some research on our program, particularly around medication-led abortion. Sorry, midwifery-led medication abortion. That's what I meant to say. So you can see here, this is the demographics of clients that we saw, and this is, I believe, from 2018 to, was it 2022? So we have, I'm just gonna actually flip over to my notes. Sorry, what you can see from this is that we have a pretty broad range of clients across age, so mostly between 20 and 40. We do have a few clients who fall either below that age range or above. Many of them are pregnant for the first time. However, some of our clients are pregnant 5 or more times. Most of our clients have not had an abortion before, but there's still a fair percentage of those, over 33%, who have had an abortion in the past. And then the gestational age. So we see people, we've seen 6 people in those years between 4 and 5 weeks, which is actually quite impressive because that's quite early. And then most of our people kind of fall in the before 7-week mark. And then we have a few up to 8 weeks, and up to 9 weeks. And we'll talk about why that is in those demographics later. But you can see that we have quite a short time from first contact to initial care in this demographics. And I think this is where I'm going to pass it over to Kate.
Yeah, thanks so much, Mona. And I just wanted to highlight that the demographics that are being shared here are for a shorter period of time. So as Mona mentioned, we started in 2018, but I was able to get a wonderful AOM grant looking at some of the outcomes that we had that we'll be sharing today. But it was for our time from when we started in end of 2018, and chose to look at the data right up until we started offering only virtual care. Sorry, the option of only virtual care. So people could just contact us without coming in. So all the data that we're sharing today is in that window, which is that 2018 to the beginning of 2022. And then my next hope is that we're able to look at what happens when we're able to offer people not having to come into the clinic to receive this and compare some of that as well. So with that in mind, we did see that there were some changes or some differences in distance traveled. So the majority of people really did fall in the range again of that middle, like 5 to 50 kilometers. The people that we saw who had to travel less than 5 kilometers all fell within our postal codes that we were looking for. So I'm always happy to report that we are sort of meeting the population that we are hoping to meet, with about a fifth of our clients at that time coming from our very small 4 postal code area, which probably would have had to travel much further prior to us being there to be able to offer that. And then we also see on the flip side that there were quite a few people that needed to travel quite far, so that over 50 and over 100 kilometers to access care in that time. With that in mind, these were all clients that anytime we spoke to them, we did try to find them care closer to home. They were not people that we sort of took the phone call and then were like, yes, make your way in. But for whatever reason, they did choose to still come and see us. And we do have colleagues sort of from the Hamilton area, out in London, in the KW region, and in Toronto that we are able to refer to that work really well. But a bit of an abyss sort of south of us in the Niagara region. So a lot of the people were coming from there where we saw those longer distances traveled. So just going to quickly walk through what happened with our visit. So over this time period, we had, and this was a retrospective chart review, about 104 individuals that we had charted that contacted us. And most of those were phone. And so Mona had also mentioned this earlier when we're talking about phone conversations. People often do come in through the pager. It gives us a chance for them to talk to one of the midwives. We can do a bit of screening. We can make sure that they are appropriate for medication. We can figure out how far. We can give them some information for them to decide whether or not medication or procedural is a good option. Are they meeting some of the criteria for us in terms of age or gestational age limits? That is another thing that I had in my notes to note. In the time period that we were doing this, our medical directive was only until 9 weeks. So you'll see a lot of this refer to 9 weeks, but there have been some changes to the program that we'll talk about that that changed that time limit as well. So with that, we had 6 people that we just on that initial consult came in person. Those were often people from the family healthcare team that had gone in to see their family doctor in the same building in the same we all work together, and that they sort of knock on our door and say they're here, could you see them, and we see them in person, or people that had just heard about us and walked in. But the vast majority end up with that phone discussion first. From that, we lost about 14 individuals. Some of them were over our gestational age limit, some of them chose to move on with procedural, some of them continued with their pregnancy, and some of them were not pregnant. So from that initial contact, we lost about 14 individuals, which left us with that initial visit. So phone contact or initial visit, or initial contact, and then that in-person visit is the initial visit that we typically do, where we prescribe a prescription or provide a prescription. We did, in the vast majority of these cases, have people come in. That was a requirement based on our medical directive. However, we had a couple of outliers. So 2 were by phone. In both of those cases, they were people that the initial contact were the in person where they walked in. We needed some additional information and then followed up with the prescription visit by phone, and then lost 4 people to no shows in between. And then between our prescription visit, so that initial or prescription visit, and the follow-up visit, we had some losses as well. And I'm going to break that down because we also had some other changes that happened between just through the middle of the data we were looking at. So about halfway through, we moved from requiring our follow-up visit to be in person to also being able to offer it as a virtual visit, which meant that only one of our visits in the data we're looking at needed to be in person. So when we divided those two out, oh no, I need to go much, much faster, much faster. Okay, when we divided that out, we found that not a lot of changes happened whether people chose to come in person or not in person in terms of no-shows. So we had about the same number of no-shows, but lots more people chose a virtual follow-up, which makes a lot of sense. Our visit summary is that we were able to offer the vast majority of people a same day or within 1 or 2 days. Most of the people that we saw that took more than a week to see were by client decision. They didn't want to come in, or they had a work schedule that we were working around. The other thing I'd like to highlight on this slide is just the pager. So we had about 48 pages out of 450 points of contact. So people felt they could contact us, and that was really important for follow-up. A huge benefit of being able to offer midwifery services and carry that pager. I'm going to hand it back to Mona, who's going to help me fly through the rest of these.
Yeah, so our outcomes, so like Kate mentioned, we lost 11 people to follow up. So those outcomes were unknown, but we had out of 109 in that period, medical terminations, we had 106 that were successful with no follow-up required. So that's 97%. We had 3 people who had retained products of conception that did require follow-up and no ongoing pregnancies. And then those people that required follow-up, basically, Kate, correct me if I'm wrong, but I believe those were people that we would then follow up with gynae for, right?
Yes,
Those were
and
not people that we gave a second prescription.
No, at this time we weren't
yeah.
doing second prescriptions.
Yeah. So then the method of determining the outcome. So for 95 of those people, it was through blood work. 11 of those were history, and then 3 of them was based on ultrasound. 144 people were seen for care, 18 referrals to gynecology or procedural clinic. And then, so that would include people who opted out of the medication and wanted a surgical procedure. We had the 3 retained products of conception. Our gestational ages were up to 7 were more than or equal to, less than or equal to 9 weeks. Is that? Oh, no, they didn't.
More than 9 weeks, we had to refer.
We denied them. Sorry, that's what that means. I'm so sorry.
Yeah. No.
And then, so 8 had requested the procedural option, and then we had no consultations that were for people who required additional pain management. Our secondary outcomes, so we looked at, well, I didn't, Kate did. Kate looked at ER visits, infection, hemorrhage, blood transfusion, ectopic and ruptured ectopic, and ICU admission. And of that, we had 1 ER visit, 1 hemorrhage, 1 blood transfusion. And am I allowed to say what I know about that?
Yeah, it's all the same person.
Yeah, it's all the same person. Yeah. So then we had to do some adapting to improve access. So obviously the pandemic was a big change for a lot of healthcare providers. And for us, it really resulted in more of an emphasis on trying to switch as much as we could to a virtual setting. So updating our medical directive to allow for a no-touch medical termination, which would allow us to provide care without people coming into clinic. We also had a change in our RH guidelines, which allowed us to not require ROGAM for clients who are RH negative. And then there was also an update to our medical directive that allowed us to provide mifepristone and misoprostol up to 10 weeks and 6 days off label, because it's approved as it's only approved up to 9 weeks. Oh yeah, and we no longer required ultrasound, because when we first started this process, we had actually held ultrasound appointments every day. We could send somebody into an ultrasound clinic if we needed to, same day. With the pandemic, the ultrasound clinics were no longer able to accommodate that. So one of the things that we did, and as wait times were increasing in the community for pelvic ultrasounds, was shifting to not requiring an ultrasound prior to medication abortion. So some of the challenges, obviously operating under a medical directive has some challenges associated with it, and also has a lot of challenges in terms of increasing access across the province because it's not always possible to get a medical directive in place. Balancing timely access with appropriate care. So, like we want clients to have timely access, but sometimes we need them to be able to do their blood work first. We need an ultrasound first because there's suspicion of an ectopic or uncertain dates. Um, uh, Needing to rely on that interdisciplinary support is also a factor that it can create sometimes challenges in care. Um, we obviously had to set up relationships with pharmacists to ensure access to the medications. And then some safety concerns around visibility of an abortion clinic is one of the challenges that I think is still a factor because when you're working with other healthcare professionals, they're not necessarily keen for you to be broadly advertising your abortion services.
I feel terrible, Mona, that I'm gonna cut you guys off, but it looks like you are at the
That's it.
end. Anyhow,
Yep.
that's perfect. I am hoping, I know we don't have really time for live questions, but I'm hoping everyone will just throw them into the Q&A. And if you guys have a minute, you can stick around and answer them. I think people often have questions about the logistics of having the medical directive. But I also was going to say quickly before we transition over to Pilar, just that this could get published at some point, on top of all the work you already do, because I think it really shows the safety of this approach of like the no-touch abortions and midwifery managed work, which there's a lot of mythology about the safety of that. And I love that your data is as good as it is. Yeah. So thank you both. And yeah, please feel free to throw some questions to them in the Q&A. And
Thank you.
otherwise, we'll move on to our next speaker, which is Pilar Chapman. And so feel free to take control of the slides there, Pilar. She is a registered midwife who will be presenting the hospitalist midwife model at West Lincoln Memorial Hospital in Grimsby, Ontario. So I'll let her take it away.
Thank you. Hi, everybody. Thanks for joining today. Today, I'm going to be talking about our EMCM at West Lincoln Memorial, which has, I think, some really hopeful results. So, advancing the slides is step one, though, isn't it? There we go. So we are a level 1 hospital that is part of Hamilton Health Sciences. We're a level 1B actually, and we're situated in Grimsby, Ontario. So it's a bit unusual to have a level 1 site that is in a semi-urban area like we are. One of the things that's interesting about our hospital is we are where rural family doctors learn to do their residency in rural medicine. So that's a really interesting element to our hospital. In case people aren't aware of how levels of hospitals work, a level 1 means we do not have peds on site. So our newborns are cared for either by family doctors or midwives. The B portion of the level 1 means that we offer 24 hours a day, 7 days a week coverage for C-section capabilities. We are staffed, our department, by 4 obstetricians. We have 8 family doctors who conduct deliveries, and we have a group of community midwives, 6 midwives, and West Lincoln was one of the first hospitals in Niagara to offer privileges to midwives. So that's kind of a fun fact. In terms of who conducts our deliveries, the majority of patients, so half of patients, are admitted under obstetricians, 57%. 11% of our patients are admitted by family doctors. And our midwives do a large component, like 30% of the deliveries at West Lincoln. And then if you look in the little subtext there, you see that obstetricians deliver a bit more than the people that they admit. They do 64%. But when you look at the midwives and the family doctors, we do most of our own deliveries, except for C-sections and assisted vaginal. There's essentially not really a transfer of care rate if you admit your patient. What's also interesting about our site is we have a low transfer rate for newborns to go to a higher level center. So remember, we don't have peds. So what that means is if a newborn needs more ongoing support than what our site can provide, we have to move that baby to a higher level center. So examples would be if the baby needed to have IV infusion to manage hypoglycemia, if the dextrose gel wasn't working, for example, they would need to move, or TTN that they need ongoing respiratory support, we wouldn't be able to manage, or other more critical issues. So when you think about when I work in a larger center and how many babies end up in the special care nursery, this is a really low number of babies that needs to leave our center. And one of the reasons for that is I think that we've done a really good job as a site of figuring out what our inclusion and our exclusion criteria are. And I won't get into the details of that except for a high level overview. And really, we try and keep our population low risk. So by low risk, examples of our inclusion criteria to deliver at our hospital would be your 36 weeks, it's a singleton pregnancy, your baby's in a vertex presentation if you're planning a vaginal birth, your index BMI is 45 or less, and GDM diet controlled is an inclusion, but if you need insulin, then we would need to find a care for you at a higher level site. So I've had this idea for a really long time, actually, but when we started having EMCMs, I started to get more support to put in a proposal. So in the fall of 2023, our proposal was supported. And just to explain what my idea was, I really think there's two arms to the project. One is I think we need to do a better job in supporting interpartum care providers. I think it's hard to be an interpartum care provider. We're seeing huge attrition rates, not just of midwives, but also of family doctors who deliver babies and obstetricians. And we need to figure out a better way to do this. And I think it's stressful to be an interpartum care provider because you're either on call for like a 12-hour period with a really high volume, that's crazy, or you're on call for a long period of time, but getting interrupted multiple times in those days, and lack of sleep, and always being pulled in a different direction. So my idea is let's use the hospitalist midwife program to support interpartum care, not erode it. And then the other part of the project is to strengthen the connection between hospital and the community primary care providers so that people aren't waiting to be discharged from hospital because the community care provider is worried, can I access hospital services if I need them once that patient is discharged? So I didn't even know what the word KPI was before I put in an EMCM proposal, but I'm starting to get schooled in these terms like metrics, for example. But the two KPIs or key performance indicators we're looking at is length of stay, as well as how babies are born at our site, and to see if the hospitalist midwife program can have an impact on that. And one thing I want to highlight is West Lincoln has had a long tradition of supporting normal birth, and we hoped as hospitalist midwives to strengthen that culture. So people often ask me, like, what do we do as the hospitalist midwives? And whenever you hear me using the word I mean we as the hospitalist midwives. And our project is funded to have 5 full-time equivalents. And that is based on a 24/7 days a week model where we're doing 12-hour shifts. So one component of our job is triage. So our job in triage is to be a provider on site who is conducting assessments. Now, it's not to replace a nurse. A nurse is still involved in the care, but we're conducting assessments and making decisions, as well as updating the MRP. And how we update the MRP depends on what the clinical scenario is. So we have drafted a memo of understanding, an MOU, so it clearly outlines when I need to just send that person a message, the provider, or when I need to pick up the phone and call them. So examples would be, 2 o'clock in the morning, primate comes in early labor. I would assess the person, decide they're not in labor, if the patient needs it, or some narcotics, and then I'm just sending the provider a direct message through our EMR system. If I was assessing someone with hypertension, in our MOU, it has a very clear outline as to if a number of the blood pressure is 160 over 100 and lower, I would order the lab work, do the full assessment, and then pick up the phone and call the provider to give them an overview. If the blood pressure was higher than what I said initially, I would pick up the phone and call them from the beginning. So that MOU, that memo of understanding, really helps sort out what my role is. In inpatient care, which is the other part of my job, I do a lot of reassessments of patients while they're in labor and then interventions to keep the labor process going along. So if it's a midwifery patient, the midwife is at bedside when the patient is in active labor, not before that. If it's a physician patient, I'm involved as much as the physician wants me involved, and usually that's quite a bit. So for example, I would be doing arms, I would be putting IUPCs in, I would be doing scalp clips. And also the hospice midwife would attend deliveries if, like as an NRP lead, if that's what's needed. Then if you think of our newborn population, the babies who are born with a provider who has hospital privileges would not be under my care, but 72% of our babies are born without a doctor with privileges. So those babies, the hospice midwife is the MRP. And then we also run an outpatient post-delivery clinic. And so in that clinic, we can do early supported discharge. So if they go home before 24 hours, we can do the newborn testing. And we can do bilirubins, order phototherapy. Midwives at West Lincoln have always ordered phototherapy, so this is not a new skill for us. It's just that the hospice midwife is doing it now. And another component of our care is doing phone calls and follow-up. So if a patient would like it, and a lot of our first-time moms do, we do postpartum phone check-ins to see how they're doing. And I find that simple 15-minute phone call can solve, well, first it builds confidence, and it also saves a lot of unnecessary trips into the hospital. So if we look at our length of stay, this is an interesting statistic. The green shows what our length of stay was at West Lincoln before we had hospice midwives. The pink shows, and sorry, I should go back a step. This is looking at a 6-month period, the same 6-month period of April 1st, September 30th, comparing the year 2023, 2024, and 2025. So it's not a full year. The green shows what we were doing before we had a hospice midwife. The pink shows in last year when we had a hospice midwife really working very, very part-time. And then in the blue this year, since May to now, we've had a hospice midwife 24/7 most months. So sometimes we have like 5 or 6 shifts that aren't covered, usually nights, but generally we have a fully staffed hospice midwife. So what's interesting is you see in the green, our early discharge rate used to be 27%. And now when you compare it to the blue, and that was our community midwives, of course, and then when you compare it to the blue, we see that of the people who deliver at our hospital, 47.5% are going home under 24 hours. And to be completely honest with you, I had no idea how interested physician patients would be with going home early, but it turns out they're way more interested than I ever thought. And it's all about, I think, going home to sleeping in your own bed. And I know that sounds funny, but it's true. Our discharging and the timing of it often is people go home at bedtime, whether that's 6 hours after delivery or 10 hours after delivery, and sleep in their own beds. When they come back for the newborn testing, I don't schedule it right at the 24-hour mark. I schedule it between 24 and 72 as to when that makes sense for the family. Usually it's between 24 and 36 hours they come back. And also that visit is a quick visit in and out. So it's not like they're sitting there for 2 hours at a clinic. It's usually a half an hour appointment for them to come. And then we're checking in on both both people in the dyad. So this is something that I think is a really impressive stat. I think it's also interesting to see that our length of stay for over 36 hours has gone down by more than half as well. So that's also interesting. So I also wanted to look at, how babies are born at West Lincoln and whether or not having a hospice midwife impacts this. And I can't say for sure with just one, 2 6-month periods of data and say that this has had a direct impact, but my gut feeling it has, and we will study it in the years to come and see where we land. So if you look in the orange, you see that West Lincoln, last year, we did in that 6-month period, we did 208 deliveries, and our section rate was quite low. Our vaginal birth rate was 76%. So when you compare it to the light orange, you see other level ones, the section rate is 68.9%. So we're quite a bit lower, that was vaginal birth rate. Our vaginal birth rate is quite a bit higher than other level ones. So that's a cultural thing. And then when you look at the pink, the second part of the data, you see what this year has been when we've had the hospice midwife on site. And you see our vaginal birth rate has gone up by 4.5%. And I think that's really interesting. And I think as a gut feeling of what I think is going on, I think it really helps to have a provider on site making decisions around interventions if need be. I think sometimes reassessments are delayed because the provider is busy doing other important things with higher acuity. So, starting oxytocin at a low dose when it needs to be, A huge part is also doing interventions to keep the labor going. So like rupturing membranes or putting in IUPC, you know, at 2 a.m, because the nurse is like, I think the contractions are adequate. I've been really quite amazed that IUPCs can sometimes really show that even though we have a contraction pattern that is appearing adequate and we have failure to progress, it's because the strength of the contractions aren't actually what we thought they were. Super excited what's going on at the IWK, because this full moon concept, like I know that us helping with the position changes in labor has really helped also increase our vaginal birth rate. Families are really loving this model of care. We're getting glowing feedback from our families. Things like, I was cared for by a team and I felt well cared for, are terms that we often hear. And our providers are really appreciating having the extra support. I say we have 4 obstetricians. Last year, 2 of our obstetricians were on parental leave and we weren't able to have a locum. So those poor OBs were doing 1 and 2 call. And this model really, really supported having them stay sane during that crazy period of time. One of the things that's super important to me as well is that we upskill our hospitalist midwives. So some of the skills that we focused on in the last year to make sure the midwives get the skills is in point of care ultrasound. We've become trained in ACORN, acute care of a newborn. We're looking into IO and UVC, like a more intensive training. And currently we're doing surgical assist. And one of the interesting things about our program is our 6 community midwives are also casual midwives at our site. And I can't say, like, I've so appreciated their support this last year for filling in the gaps while we were hiring staff. They were able to be paid for the training in those areas that I just described, which was a super exciting thing, to be paid for your time to train. Like, what a novel concept. So I've just rushed through that because, of course, it went much slower than I did when I timed it. Is there any questions?
Thank you so much, Pilar. That was fantastic. And I especially love the piece where you've tracked the data that you've tracked. I just think that's so helpful to have to show the impact that your program has. So well done on figuring out not only what a KPI is, but also how to measure it and share it.
Mhm.
And yeah, I'm quite certain that your hospital, you probably kept this model is probably the reason your hospital has been able to stay open, to be honest, with those types of leaves for the OBs, and I'm sure nursing shortages as well. So that's well done for your community. If anyone has any questions, feel free to throw them in the Q&A. Otherwise, I was going to start out with a question around just in terms of how much you guys do and how much upskilling there's been and what you take on in your center. Where do you see the program sort of continuing to grow and go? Like, it almost feels like nothing's out of the realm of possibility for your team.
One of the interesting things we're going to be doing starting very soon, like January, will be the surgical assists for the hospital. So for C-sections, I mean. So what I'd really like to see in the future is like the hospitalist midwife continues with doing the interpartum care. And then we're able to hopefully secure more funding to strengthen the outpatient care, because I think that that's a part that, as we get busier with our birth volumes, that's a piece that could fall away if we don't get more funding. But definitely I see more of that, like continuing the interpartum, but building out the outpatient part as well.
That makes a lot of sense in terms of like the next logical step. And just like in terms of sort of accomplishment wise, like what sort of advice would you have for someone who's looking to set up this model? Because we want to set up a similar model.
Right.
Obviously we're in a very, very different position in being a tertiary care center, and I think our volume's 6,800 births. So obviously a little different, but yeah, any advice for people who want to get a hospitalist model up and going?
I actually made a slide on this because I was thinking about this, and I think one of the things that's important to do is to kind of, before you put in a proposal, is to really ask your community what do they need and figure out what the gaps are. Ask a lot of questions. You can have a strong idea, but you need to stay open to what actually is needed instead of your own impression. So for us, even when we got the EMCM funding and we couldn't quite use it yet because we didn't have the staff yet, some of the midwives helped me join our family practice group to care for the unassigned newborns. And I'm telling you, doing that work really showed where the gaps were for me. And that was very, very helpful. I think success is also easier where you have interprofessional collaboration already existing. Relationships matter, really build on that. I think it's important that your EMCM has a midwife who's hired to coordinate. I didn't realize the strength of that. And that was something that was passed on through looking at the research of EMCMs that are successful versus not. And now being able to use some funding to use it for the person to coordinate, like to do the things that make the project happen is important. And then data collection. I wouldn't say I'm a data collection person by heart, but I understand that it's important to learn from, like you, Lauren, you've taught me that, and other midwives have. And metrics matter, data matters. And even like when you look at the Full Moon Project, like showing nurses what the outcome of their efforts are at the bedside, I find that that really engages people.
I could not agree more in terms of the power that data has, and honestly, like your outcomes are very, very powerful. So hopefully you'll find, you know, all that free time to publish it too someday. But you know what, starting starting with good KT at these types of events is great, because you know now we're all a little bit more aware of the impact. So thank you so much. There's a couple comments in the chat if you want to take a peek at them while I move on to our next speaker. But yeah, thank you again, Pilar. And that wraps up sort of our first three presenters that started describing their EMCMs. And we're going to move on to our next section where we're going to focus on two midwifery-led programs, one based out of Michael Garron Hospital and the other out of London Health Sciences Centre. So I'd like to welcome Sarah Leslie. If she'd like to turn her camera on, I think I saw her name here at one point. And she's welcome to take control of the slides. I believe her co-presenter, Melissa Chan, was unwell and potentially not able to attend today. So I think Sarah is going to take this on her own. Yeah, I'll let you get started, Sarah, and we'll share her bio in the chat.
Okay, great. Hi, everybody. Yeah, I'm sorry. Our dear friend Melissa is unfortunately not here today. So speaking as the person who is the developer and working with a variety of different stakeholders, I am the person who is great to do this talk, but also I do occasionally do shifts at our family newborn clinic, which we call the FAN clinic. And we did spend a lot of time trying to figure out which was the best choice around the name. But we came up with the FAN clinic, and which also is then affectionately known as the FAN Club. And so this is just a little bit about the presentation today. I do apologize for, you know, some of the slides I don't know as well, but I hope I will do them justice. So originally this started when we think about our timeline back in May of 2023 when we put in our submission, and Christy Lockhart, the chief of midwifery, did that initial proposal for our EMCM at Michael Garron Hospital, which is in Toronto, in a very urban, kind of suburban part of Toronto in the East End. We had immediate support. We have a very good relationship with our colleagues as midwives. And so we put that submission in. It's kind of on the heels of the MGH hospitalist that we used during and had funding for during COVID. So it was a nice evolution, so to speak. And so we had the support, obviously, of the midwives, obstetricians, family doctors, and pediatric team, as well as the clinical programs team that oversaw all the different clinics throughout the hospital. The funding was approved and effective as of January 1st, 2024. So as you can see, we are pretty new EMCM, and myself and Christy at that time, the next like 6 months, basically started to develop what we wanted to do. We were waylaid a little bit because our space wasn't available right away. So we did a lot of administrative and figuring out this and that up until about June of 2024. And then the construction started at that time in our new space. And I have a few pictures to show you. So we work within a larger clinic space that was being developed with the help of the Bank of Montreal in Michael Garron Hospital, which has gone through a huge bunch of renovations and new building over the last several years. So the Child and Youth Center has pediatrics, the neonatologists, they're all running clinics, the breastfeeding clinic, all through our clinic, as well as the early pregnancy clinic, which is miscarriage care for the folks in the first, I believe, 12, 14 weeks pregnancy, and they manage ectopics and miscarriages for everybody in the community, OB, midwifery, and family practitioners. During that time, we were developing our MOU, which we already kind of had because we had it for COVID, but we changed it a little bit, obviously, for this scenario. And we started our staffing plan in that spring into the fall of last year. Initially, we had the plan that the midwifery clinic, which at our clinic, the Midwives Clinic of East York Don Mills, would have the majority of the people working in that clinic. And so we learned over the first couple months, though, that having a designated person work in the clinic would be ideal for continuity. I was doing administrative protocols, etc. But it was at that point we realized the importance of continuity for one person to be staffing it most of the time, obviously sharing the rest with the practice group, filling in shifts. So at that time, we started looking for a midwife who wanted to be hired as an employee by MGH or Michael Garron. And so we had folks who were self-employed working in the clinic. And then Mary started in January of 2025 as an actual employee of the hospital as well. So we had both of those folks working in the clinic every day, which is a 7-day-a-week clinic. We first started seeing clients in October of 2024. So we are literally just at 1 year this past week, which is unbelievable. And because we were waiting for our construction to be finished, we ended up being in like the non-stress test area in the unit, whereas when we moved into our new space, we actually were on a completely different floor along with the other clinical programs. So we originally were embedded in our labor and delivery unit and then moved down to our room now. So it's absolutely beautiful. I will show you some pictures before I am done. But these are the main goals of our clinic. We really wanted to reduce the emergency room visits. We had a lot of folks, we have a lot of newcomers, not always understanding English, accessing emergency room. And we really wanted to remove those folks from that environment, especially during the middle of the night, and that didn't need urgent, like emergent care, but they needed to have access to somebody to look after them about, and often related to people who are unattached to a family doctor. And so the dyad would sometimes have one, like the baby might have a pediatrician, but the parent might not. We wanted to provide care for unattached folks. So there's a lot of newcomers, as I said, and so we wanted to make sure that those folks were able to get care postpartum from a midwife through that first 8 weeks, which was lovely that the CMO was opening that up so we could look after babies up until 8 weeks and provide a little bit more buffer for our new families to find a care provider by 4 months postpartum. Obviously, it was then to connect the community with their primary care provider going forward. And so we are still strengthening those ties to the family docs, for instance, in our community. And then lastly, we wanted to provide a different way for midwives to work. We got a taste of the hospitalist experience, hospitalist midwives during COVID, and there were many of our midwives who were in our midwifery practice group who were interested in working in an environment where they got to still use their skills, but not obviously accessing like working through the night. So that is the main goals of it. And so when we think of the main goals, we wanted to enlist a multi-pronged approach. We wanted to keep people out of emerge, so we worked with the emergency department. We're working with our practitioners. A lot of our unattached folks, they're seeing an obstetrician during pregnancy, but they don't have a plan for postpartum. And so that allowed our obstetricians to start talking about the FAN clinic in pregnancy to prepare them for and to normalize that, so that when they got to the postpartum room and the nurse starts talking about what's the plan for follow-up after after your discharge, they can introduce again the family and newborn clinic. Of course, the chief of midwifery, obstetrics, pediatrics, and family physicians were all involved with the development of the guidelines that everybody is following. So it's quite a process in that the postpartum nurses are checking and seeing if people have family doctors, are they unattached or not. That is one of the ways that we're getting people into the clinic. And when we started in January, really when we started to look at the data, we had like 24 interactions a month, very small. And this past week, for instance, I've done almost exclusively FAN work, and I have very full days. I'm seeing 6 to 8 patients a day. So it's really grown over that course of the last 10 months of data tracking, and having upwards, I think we've seen about 900 patients interactions since then. So as a new clinic, we're very happy with our goal and having so many people circling around these new families that don't have access to healthcare at all. When we think of the 2 prongs of our clinic, we have also something called an early discharge program. And so we have folks in our community having baby 4, 5, 6, and those folks do not want to stay at the hospital, even though they don't have a midwifery group looking after them. So their OBs will talk to them, family doctors talk to them about early discharge, and they will go home usually anywhere between 6 and 12 hours with the intention of the family newborn midwife coming to see them for their early discharge. Similarly, anywhere between 24 and 72 hours. The way that our clinic is structured is the morning first bit is for the early discharge program, and then the afternoon from 11 o'clock onwards is about the clinic being run within the hospital. So we have a dual situation going on right now. It's working very well. Originally, we set it up as 2 home visits. We weren't finding we would use it, and instead we're just doing 1 in the morning, and then are able to see some repeat billies that are needed for midwifery clients or family doc clients as well. So we use the time. Our clinical time is about 9 in the morning until 4 o'clock in the afternoon. We do all of our administrative business, so we do it around those appointments. And our day is from 8:30 to 5:30 at night. The on-site ones are like any postpartum, with the exception that we are also receiving folks that could have gone to emerge, but we don't want them to. So this is from midwifery, family physicians, and OBs, and this is our semi-urgent consultation. So if a midwifery client is being assessed at home at day 4 and they are found to have high blood pressure, we used to send them to emerge, and they would be there for hours. And as long as it's not 4 o'clock in the afternoon, they'll come into FAN and they will have their blood work taken, urine, and whatever else the obstetrician that's working that day. After we've done the initial assessments, we let them know they're there, and then they tell us, okay, let's do this, this, this. The last couple of days, I had a couple of OB patients come and they were coming because they are taking high blood pressure medication, but the OB is nervous that it's not the right dosage. And so this allowed for us to change the dosage for them. We do have protocols. We're still developing them. We have a FAN clinic manual because we have about 5 people currently working in FAN. Our person who was the main lead is on had a baby a couple of weeks ago. And so we have lots of protocols. And this helps us to create symmetry from one midwife to another. And this is some of the art that's in our clinic, which is lovely. So the self-referral is also another thing. So we refer and ask them to call or email our clinic. And so they are self-referring, and we chat with them on the phone and make a plan what makes the most sense for their next appointment to come in to see us. This is a little bit about how we work within our group to create that clinical excellence when we have 4 or 5 different people working within the FAN clinic. So we have our partners with the early pregnancy clinic. We actually share the same space. And so it's a very holistic female environment or uterus environment, I guess I should say. Anywho, and so there is a handover document that we use between midwives from day to day, because it's not a midwife working every single day, day after day. So we have a handover document, so we make sure that we're not missing anything. And we have a text thread within Microsoft Teams that allows us to communicate if someone's sick, for instance. That allows us to also make sure that we're not missing any days of clinic. So we did a little collaboration advertising. So we got, we used a little bit of our extra funding for our little pins and hats. And you can see some of our colleagues here wearing the hats. These are pediatric nurses, OB nurses, OBs, and this is early pregnancy. So that's Jenna and Tiffany who work within our space, and you can see their little sign. We also have created a newsletter. So this newsletter is to go to all of our other collaborators, and it talks a little bit about our different kinds of appointments and education around how we've referred to MGH FAN clinics. So that also can be quite challenging because sometimes we get a referral form that's blank with one thing on it. So we're constantly educating as a new clinic within this hospital. Every single room that a postpartum or pregnant person is in has a little, poster, and we just finally got some ability to do that in Emerge as well. So that'll be going up this week, and it just has got a bunch of different ways how people can contact us, which we do get a lot of self-referrals. And our family and newborn clinic midwives wear this cute little shirt just because it makes it really easy for people to see, and just gives us a bit more advertising amongst our colleagues. And then these are the things that we're working on. So we're all the different aspects, which I kind of already talked about already. This is our space. So we have our admin area, and we have 2 clinic rooms, and early pregnancy clinic works in the morning. We work in the afternoon. So while we're out doing our home visits, I know it was worth the wait. While we're doing our home visits, early pregnancy clinic is running in the space, and then the scale and the diapers and all that stuff is removed, and so then they can come into the space in the morning and feel like this is a clinic space that's very oriented to folks that have uteruses and vulvas, etc. So we spent some time early pregnancy clinic and us working through how can we make this space as inviting as possible. These are cells, which is kind of our biology. We like that kind of aspect. So those are in the main clinic space. And then we really wanted to highlight our Indigenous space, Indigenous landscape, and who we are and where we're situated. So we worked with an Indigenous artist who has done 2 beautiful. This one is one from her already catalog, but we did actually spend a little bit of money. Somebody had donated, and we're able to have her make this for us. We're getting it this week, actually. We're so excited. And then lastly, this is just where we are. Like, you can see how we're such little baby infants of in the EMCN right now, but we're hoping to grow our skills. So for instance, we had somebody who wanted to come to us with a breast abscess. Like, our midwives don't usually manage that. So that's kind of the example that we're hoping to work on. Collaborative excellence. We already live within an environment that's super collaborative. But, it's really just about creating more strength, especially with Emerge, who's a very big group of physicians. Community engagement, which I think we're well on our way. Increasing program funding. I think we could have 2 midwives working here each day. And then obviously the points about data and metrics is our next big step. And we just signed up with Born. So we're hoping to do that as we grow and establish ourselves. So that is our chat. I think I'm pretty much on time.
Yeah, you were. I really appreciate you sharing everything. And honestly, I think you have maybe the cutest branding that I've ever seen. So well done in terms of visibility and like just creating an identity for the clinic, especially when, self-referrals are so important for people to access this kind of care. So it helps with the visibility. So what I'm going to do is maybe just ask anyone who has some questions or comments for Sarah to throw them in the Q&A and the chat. And thank you so much, Sarah. If you can stick around to answer any of those, that would be great as we move on to our next presenter, Natalie Taylor. So I'll see if Natalie can take over the slideshow from Sarah, and I'll let her get started. So Natalie is going to talk a little bit about a somewhat overlapping program to the FAN clinic that runs here at London Health Sciences Centre. It's our midwifery-led Billy clinic. Natalie's a registered midwife with the TIME program, but who has also worked in the Billy clinic as well. So I'm going to let her take it away. She did warn me that she was having mic problems at another point. So let me see if I can. Yeah, I don't think we can hear you, Nat.
And I don't need to do anything, right? Like, she'll just take. Okay,
she'll just take it over. Yeah. So it's not your issue, Sarah, but yeah, Nat was saying that she was having some mic issues before. And Nat, if you do need to log out and on, that's totally fine. I'm going to actually just jump ahead on the slides to our kind of wrap up slide while Nat fixes her mic issue, hopefully. And just wanted to share that we have some evaluations for today that if you have a minute, you can scan the QR code. So I'm going to quickly show those while we wait for Natalie. And I also just wanted to do a really quick promo for tomorrow. So tomorrow is our final day of the conference, day 3, and it is our leadership theme. And the most exciting piece is that we're focusing on thriving in midwifery leadership tomorrow. And we have 3 very well-known figures in the midwifery leadership world. We have Carol Cameron, Christy Lockhart, and Aileen Edwards, who will all be presenting, and they will also be participating in a panel discussion afterwards. So hopefully everyone can join tomorrow. I might have my tech people throw the links up into the chat. Yes, I can hear you, Nat. Awesome.
Oh, amazing. Okay, I'm thrilled. So sorry to interrupt you. I just wanted to say
no worries. I'm glad you did. Yeah, I was just doing some of the wrap up stuff. So I'm actually going to give you like basically right up until 2, Nat. So you should be totally fine for time. So you can use your same amount of time. And I'm going to have Meg, she's going to throw the links to register for tomorrow, as well as the 2 links for the evaluation yesterday and today as well. All right, take it away, Nat.
Well, sorry, this looks like it's. Give me 1 second to go back. It seemed to like show me the end.
Yeah, that was me. I had scanned forward. Yeah, go right ahead.
Okay. So hi, I'm Natalie, and I am thrilled to be here today to talk to you about our Department of Midwifery midwife-led Billy Clinic. So before I start, here's my disclosure slide. I'm currently an independent contractor for the midwifery-led Billy Clinic that I'm presenting about today. I am also a very proud employee of LHSC as I work at LHSC's EMCM as a midwife. Okay, so we're going to start with the patient perspective at our Billy-led or our midwife-led Billy Clinic. If you deliver at LHSC and the newborn screen tests at 24 hours show that a repeat jaundice test is needed the following day, you're given a next day appointment to attend the midwife-led Billy Clinic. The clerks on postpartum have the ability to book into the midwife-led Billy Clinic, and the family is provided with a posted handout that informs families of what to expect at their midwife-led Billy Clinic appointment. As a side note, infants that have had phototherapy and now need rebound testing are also booked into this clinic, as well as others that come into the ER and are found to need a repeat TSB, as their clerk can also book into the midwife-led Billy Clinic. But regardless of who books you in, the following handout is given so that families know what to expect and to prepare for the visit. So we do ask that all families arrive at 8 a.m. This actually works well most of the time because some people always arrive early, some people arrive late. Plus our clinic is not actually in the same spot as where labor and delivery is, so it can take people a bit of time to find our location. You are told to expect that you can be here for about 2 to 3 hours. That way you'll have time for blood work, a feeding assessment where you can get your questions answered. Sometimes that means we're helping with chest feeding. Sometimes that's help with pumping. Sometimes that's help with formula and bottle feeding. And actually a lot of the time it's a discussion about all of those things. Once families get all their feeding questions answered and they see how knowledgeable midwives are, they start asking all their other newborn related questions, which we are of course happy to answer for them. We also will do a complete set of vitals, including a weight check. The weight check is done with a digital scale so that we can be as precise as possible. Then before you leave, a midwife will have reviewed your new TSB levels and advised you if there needs to be any changes to the feeding plan that you have, as well as when you need to return for monitoring. Or the midwife will typically tell you that we need to start phototherapy. And that's actually something that we can do right in the clinic. So if your TSB is within photo range or within 30 points of the photo line by the new CPS guidelines, we typically consult our pediatric floor and inform them of the situation. So if the infant is at or above the photo line, we normally review the details with our pediatric colleague and then advise them that that we're going to start phototherapy here and that they need to put the wheels into motion on their end so that we can organize a bed for the patient as we are just a morning clinic. Then we inform the family and set everything up for phototherapy to happen. Of note, like many hospitals, we don't have a lot of space. So if you are busy in clinic, then typically what that means is that you're setting up the phototherapy and moving it out into our shared waiting room. Luckily, the machine is very portable and lightweight, so that definitely helps. But we do need to move them out of our clinic room because we have other patients typically that we'll need to see as well. If the TSB is not above the photo line, but within 30 points, then we would again chat with our pediatric colleagues and we together make a plan. So sometimes what that plan looks like is that they're going to admit and start phototherapy. And other times it means that they will take on the MRP status and they will order repeat blood work in the 4 to 12 hour recommended window. The really great thing about being able to start phototherapy treatment as soon as the results come in is that it normally works out that by 10 a.m. you can start phototherapy, which then means after 6 to 8 hours of treatment, a TSB can be drawn. And in cases where not much phototherapy is needed, families have their treatment completed by 6 to 8 p.m. And then families can go home, sleep in their own bed, come back the next morning for a repeat in our clinic, as it'll have been 12 hours since phototherapy has been stopped. So a rebound can be done, and families absolutely love that they can go home, sleep in their own space, and they really feel like we're trying to keep them out of the hospital as much as we possibly can. Now, obviously, it doesn't always work out like that, but when it does, it totally makes all the difference, and it's so amazing. Now, let's shift over to what does this look like exactly for the midwife that's working in the clinic. So our clinic runs 365 days a year. Our working hours are from 8 a.m. until 12. The clinic is scheduled and designed for 4 families to be seen each day. This means that you have about 15 minutes to do blood work. And then once all your blood work is completed for all of your families, you have about 30 minutes for a feeding assessment, weight check, vitals, and that you have about 15 minutes to document each of your patient encounters. So our blood work is ordered as stat, so it typically is back within an hour. So by the time you finish all your blood work with your first baby, you'll be able to start doing the feeding assessments. If you're not fully booked, sometimes you can start the feeding assessment, complete it, and then just adjust or fine tune once you get the results. But we do not advise that the patient leave until you've had the results back, and the midwife can review everything in person with the family. The feeding assessment, in my mind, is really where families see midwives shine, and they very much appreciate it. Many families want to chest feed, but due to the jaundice piece, many are sent home from the hospital on fast flow nipples for their bottle and given formula, which we as midwives know can totally derail the plan for chest feeding. So families really appreciate that we as care providers are mindful of monitoring their infants' jaundice while also discussing what their long-term feeding goals are and coming up with a plan that gets them back to that. Some things that I found very beneficial to have when running this clinic. The first is that it is super helpful to have formula and fast flow nipples. Unfortunately, some infants really are at this clinic because they're not getting enough volume. So many times I've heard parents say that they didn't want to waste formula because it's so expensive, so they underfeed instead of appropriately feed their infant. It makes a huge difference being able to send families home with enough food for the next 24 to 48 hours so they can give the infant what it needs and not worry about the waste and the cost of that waste. I've heard numerous times it's that last 5 mils in the bottom of the bottle that people have trouble with, so they just don't put it in. When you give them enough food and more than enough, it's amazing. So if I'm telling families I'd like them to top up with 30 mils, I often say if you could put 40 mils in the bottle, that would be great, and it allows families to get the food in. As well, fast flow nipples I think are very helpful to have, and that's not something that I really understood and appreciated until I started working more with this very sleepy population, and where I had a higher volume and saw more 36 and 37 weekers than what I was used to seeing as a traditional MPG midwife. Some infants are very sleepy, and at the feeding assessment, the parents will say, we just can't get them to eat. 9 times out of 10, I feel like it's because at home they bought the perfect breastfeeding friendly slow flow nipple, but it takes a lot of work for these 36 and 37 weekers to feed from that. And so we do provide a lot of good education on the fact that the 36 and 37 weekers do not suck well, and a fast flow nipple can be a helpful tool right now to get them feeding better. And then it's also important to pair with that the discussion on how to do paced bottle feeding and show them what and how to do that so that we can eventually transition them back to feeding at the chest. Another thing that has been extremely helpful to have in the clinic is a nipple shield that we can provide to families at no cost. So here at LHSC, if you needed one on postpartum, the LC has to give it to you and you are required to pay for it. Here at this clinic, we think if you need it, we're going to give it to you for free. And the great thing is that we eventually were able to get ones that are pre-sterilized, which then allowed us to basically open up the package. If we thought that, like, yes, this person would benefit from one, we can just open up the package, show them how to use it, and then they're good to go. Whereas Originally when we started the clinic, they were not pre-sterilized. I felt that it was very silly to say we were showing you how we were helping you with your feeding and answering all your questions and sending you home and being like, here, try this, but we can't use it in the clinic today because it's not sterilized. So after a lot of advocating, we have pre-sterilized ones, which is amazing, but they are a lot more costly, which is something that we have to eventually figure out what we're going to do to get those costs down. So it's one kink that we are still working on. And then otherwise, I did include a couple pictures of our clinic space and our shared waiting room. As you can see, our clinic is nothing fancy at all, but it is the place where all this great care takes place. And I just wanted to highlight that you don't need a lot of space or a fancy space for you to be able to make this type of clinic work. Now, from a midwifery perspective, if you were setting this up somewhere else, I would draw attention to two logistical issues that would have been great to have implemented from the start. The first is the expectation for bed availability. We originally said that we would need a bed by 12 as our shift finishes at 12. Unfortunately, we saw too many times that we were being told that we couldn't come up until exactly 12 o'clock. This typically meant that the midwife would be working until 12:30 so that they could transfer the patient up at 12, give a report, clean the equipment, and then document that final encounter. So I would recommend asking for a bed sooner than before you're leaving. The second thing is having a clinic policy for when the infants age out of the clinic. We know that some infants will have jaundice that persists and that there are other underlying conditions that should be investigated in these cases. We are now just developing a policy for not seeing infants after 15 days old and figuring out who to make a referral to if the infant is seen by us on day 14 and still does have jaundice, so that a more appropriate care provider can become involved and take on that MRP status. And then I quickly just wanted to show you the graduation certificate that we have. When a family has come in for a couple days in a row, I like to print one of these out, and that's how I tell them that they've been discharged. I think every single mother that I've given this to has cried when she saw it. Now, maybe it's because she's just so excited that she doesn't have to come back again at 9 a.m. But people seem to really like it. And one person even wanted me to take a picture with their baby and the certificate, which I thought was nice. And it kind of brought you back more to like feeling like an MPG midwife, where people wanted to take pictures with you. But otherwise, so program stats. So what are our volumes? So for perspective, our center does about 6,000 births a year. The table splits our numbers based on fiscal year. So you'll see that year 1 was only 2 months and year 3 is just the first 6 months. So since we have started the program, we've met 363 different families. We've drawn 779 TSBs, and we've started phototherapy 21 times. We've had some people book in just for a weight check. This has happened as a result of a couple different things, but weight checks are most commonly scheduled if the patient does not have a family doctor. So if the TSB is no longer needed, but they didn't gain weight between appointments, we do offer them a weight check to check into this. Now, like I said, we launched in February of 2028. However, the program was originally planned to roll out in December of 2023, but this was ultimately delayed until February due to the challenges in ensuring that there was a clear admission pathway in case the infant needed phototherapy. Though it was very sad at the time to hear that the project was being delayed, it was 100% the right decision to ensure that all stakeholders and all the different departments involved understood how the infant would be going from being admitted in an agreed upon fashion and timeframe. The pathway was extensive, as you can see, and it even planned out for who would be responsible should there be absolutely no bed available at LHSC and that the patient would need to be transferred to another facility. Luckily, this has never happened, but I really do believe that part of that is because everybody sat down and figured out how we would work it through in the case that that did happen. So staffing. So how do we staff this clinic? Our head midwife typically posts a monthly calendar where midwives can write down their availability and when they want to work. Midwives are then expected to be off call in order to sign up for a shift. The head midwife then looks at the group's availability and assigns shifts. Midwives are not guaranteed a certain number of shifts a month, nor are they required to sign up for a certain amount of shifts each month. Our department has about 60 midwives, and about 20 midwives currently work in some capacity at this clinic, which obviously comes with its own advantages and disadvantages. Really quickly, we'll touch on funding. So our hospital was given funding for programming to divert people from the already busy ER. So the Billy Clinic was proposed as a way to help with that. Previously, if you didn't have a midwife or a GP that could order and follow up the blood work, you'd be sent to the ER if you needed a TSB. Obviously, we as midwives knew that we could design something that would provide families with better care. So we did, we proposed it, and it was ultimately funded. The AOM does have a great template letter to help with negotiations when you're doing non-MPG related work. I put a little clipping of that there. Of note, the AOM does also advocate for holiday and weekends to be paid at a higher rate. Since the beginning, our clinic department has advocated for those premiums, but we have not received them. We're only starting to get holiday premiums. So the letter from the AOM is amazing, but it wasn't a slam dunk in getting us everything that we wanted. And then really quickly, future hopes. Oh my goodness, at our EMCM, we have breast pumps that we provide on loan for free, and you get a free pump kit. It is magical and dynamite to be able to provide families with that. So I hope eventually we can do the same thing over at the Billy Clinic. And then one day, home phototherapy, our EMCM is also working on that, and I hope to one day be able to use that as well in the Billy Clinic. Otherwise, thank you for listening. I love talking about jaundice. If anybody wants to talk about jaundice at all, call me, email me. I'd love to bounce ideas off of you and talk further about it. If you've got an established program or you want to come up with a program, thank you so much.
Thanks so much, Nat. She really is like our local expert in all things hyperbelly related, and it's been so great to have her as part of the team. I know that we are at time, so I might actually just forward through again to our final slide here. If you take a peek in the chat, you'll see the links for yesterday's survey, today's feedback survey, as well as the link to register for tomorrow. So please make it out. If anybody has any questions for Natalie, I'm happy to leave the Q&A open for a couple of minutes here. So please feel free to throw them into the chat or the Q&A. But otherwise, thank you so much to all of our speakers for today. And just the fact that, you know, everyone is always out there talking about different ways that they want to innovate to meet client needs. And we had some really great examples today of people who were actually out there doing it. And, you know, the passion really came through because you need a lot of that to get through all of the change processes necessary for all of the models that we saw today. So thank you again to all of our speakers. I'm so grateful, and we really look forward to seeing everybody tomorrow. Take care and have a great afternoon, everyone.